Now that we've discussed primary hemostasis, let's go over some disorders and drugs that disrupt this process. First, the collagen could be deformed or mutated. It could be deformed in scurvy, which is a vitamin C deficiency where synthesis of the collagen is disrupted, or it could be something like Ehlers-Danlos syndrome or EDS, where the collagen is mutated. Next, we have issues with von Willebrand's factor, such as von Willebrand's disease, the most common disorder where a patient couldn't clot. And this could be either due to a deficiency of the factor or it could be mutations in the factor. They all are subclasses of von Willebrand's disease. Lastly, the GP1B itself could be mutated, and this is called Bernard-Sawyer syndrome. In this case, the platelet is not able to recognize and bind to this complex that it normally would. In the activation phase, there are not many disorders to discuss, but there are certainly two very important drugs. Aspirin and NSAIDs block this cyclooxygenase enzyme, which in turn reduces thromboxane A2 production and reduces the platelet's ability to aggregate. Next, we have clopidogrel, which is another drug that actually blocks this P2Y12 receptor, thereby again blocking the aggregation. In the aggregation step itself, this GP2B3A could potentially be stopped in three ways. First, there is abciximab, which is a monoclonal antibody that binds and inactivates GP2B3A. We could also have Glanzmann's thrombasthenia, which is a genetic condition where the GP2B3A is mutated. And then lastly, we could have ITP, which is immune thrombocytopenic purpura, which is where the body actually makes antibodies that stop the GP2B3A. So these are all the ways that primary hemostasis could be disrupted. To make this discussion as comprehensive as possible, let's finish this with a discussion of TTP and HIT. So TTP, or thrombotic thrombocytopenic purpura, is where Adams TS13 is the enzyme that's knocked out. Adams TS13 is important because it takes von Willebrand factor multimers. So that's von Willebrand factors attached to each other, and it breaks them up so that a single von Willebrand factor can then go ahead and create this complex with the collagen. If this doesn't happen, this huge von Willebrand complex factor multimer will actually activate the platelets by itself. This activation causes thrombosis or clotting. That's the first T in TTP, thrombotic. Then, when the platelets are activated inappropriately, they get destroyed, which is the thrombocytopenia part of TTP. And lastly, when the platelets are ultimately destroyed, you end up with bleeding or purpura, which is a type of bleeding. So that's TTP. Next, in HIT, or heparin-induced thrombocytopenia, we have this platelet factor 4 that was released by the alpha granules of an activated platelet, and this platelet factor 4 forms a complex with heparin. Now, this is the high molecular weight or normal heparin, and what this heparin platelet factor 4 combination does is it actually attracts antibodies in certain people. And these antibodies, which are IgG, will actually activate the Fc receptor on a platelet. So this complex will then cause the platelets to be destroyed, which causes a heparin-induced thrombocytopenia. The platelets themselves are being consumed and destroyed, but the patients are still generally in a hypercoagulable state for which they were receiving the heparin to begin with.